Welcome to another episode of Exercise Matters with me, Randall Cooper.
And me, Mick Hughes.
Support for today's episode comes from Premax Performance Skincare. If you're active, you focus on strength, endurance and recovery. But what about your skin? Sweat, friction and the elements take a toll. That's where Premax comes in. High-performance skincare made for high-performance people. From recovery creams to anti-chafe balms, massage creams to exercise-specific barrier creams, we help your skin go the distance. Keep your skin as fit as your body with Premax. Available now at premax.co.
And support for today's episode also comes from Learn.Physio. Health professionals, are you staying ahead of the game? Learn.Physio brings you cutting-edge education from world-class experts in sports and musculoskeletal medicine. Online courses, hands-on practicals and expert resources. All backed by the latest evidence and designed to fit into your busy schedule. To be your best, learn from the best. Get started today at Learn.Physio.
Well, g'day again,
mate.
Mick.
How are you going?
Yep, I'm all good. Now, we did tease last episode that we're going to talk about tendons today, so I'm looking forward to it. Have you ever had a tendon problem yourself?
Mate, all my life. No,
Really?
all my adult. I reckon most of my, I'd say from mid-20s. I remember I went through a period in my mid-20s when I had a stint living in Byron Bay, of all places, when I got back from the UK. Had a 12-month stint in the UK, came back to lived in Byron Bay, tried to figure my life out. And in those days, I used to run along the beach to, kind of clear my head and try and figure out what I'm going to do with my life. And all those beach day runs left me with a terrible mid-portion Achilles complaint that, I wasn't a physio at this stage. And I really battled with that, I reckon, for probably about 6 to 12 months. And then I stopped running, and running wasn't a huge part of my life. But I'd say probably in the last, I'm good now, but I reckon in my mid-30s, I'd wake up with stiff ankles and stiff Achilles, recurrent calf tears, stiff ankles for a big chunk of time. And magically, they all, especially my stiff ankles and that stiffness that you get through the Achilles, all eased up when I stopped drinking alcohol. And I don't know what the mechanism is. Yeah. I spoke to Jill Cook about it. She goes, that's remarkable. And this is, I wasn't running at the stage. And she goes, maybe it's like there's, we know alcohol's got some inflammatory effects in the body, and there are some, inflammatory kind of, drivers behind tendons and how they behave. Maybe there was just sort of low level kind of, inflammatory driver there that was just making your tendons feel like crap. And when I stopped, it was literally within less than a month, like that's early morning stiffness. And this was with no loss of weight either. Like I hadn't lost, 4 kilos of body weight to lessen the load on the tendon. So anyway, my Achilles haven't been the greatest in all my life. How about you?
I've really only had 2 episodes, tendon related. One's recently. I thought it's, again, probably just because I'm aging, I just get some mild mid-portion Achilles stuff, mainly on my right. Nothing bad, but if I go for long walks, I know about it the next day, but it's manageable. The other one, you're going to laugh at this one, is that I actually had an avulsion injury of my, it's not really tendon, but I had an avulsion injury of my left hamstring when I was 16 years old, where I got a bit over-enthusiastic at a party, and this was back in the days of MC Hammer. So, I kind of jumped up and did the splits and tried to impress a few people and ripped the hamstring off the bone. So
mate, how good?
Yeah. So that's a very. I can't believe I shared that publicly on this.
Did you get it reattached, or how did you manage? Did you have to get it surgically reattached, or did it just?
Do you know what? I went to This was about 12 months after I did my ACL, and I went to the physios that did my ACL rehab as well, and they misdiagnosed it. They misdiagnosed it as a mid-portion hamstring tear, and they didn't realise that it was. And I reckon it was only kind of like in my mid-20s where I really started to understand this injury and the mechanism behind it, and then I felt around the region. It's like, I ripped that off the bone. I didn't get an ultrasound or whatever. And it's like, well, nearly 10 years later, I'm not going to go and get it reattached now, so I'll just learn to deal with it. So it's been fine, but I'm not going to say who those physios were, by the way, either. But there you go. There's my tendon stories.
Mate. And then, your sprinting days were over. Mate, you could probably see, because I could imagine you would have been a fast teenager, fast teen. You could probably sue for malpractice and, Anyway, too
I
bad.
was,
Too bad for you.
I was great over about 20 meters, and that was as fast. I was, yep. This is fast. I ran fast for 20 meters and nothing else. So that was me.
That was
And I
it.
wasn't much of a
Yeah.
runner anyway. But the interesting thing with tendons is, as you know, like I swim a lot. Touch wood. I've never had rotator cuff issues. I've done a lot of skiing, and I've had very minor patellofemoral symptoms, no patellar tendon kind of symptoms at any time. So it's good. Tendon-wise, I
touch
seem
wood,
to be
mate.
fairly hardy. Yeah, but I'm pleased, like I said in the episode last week, that we're talking about this because it is something that can affect a lot of people. And I think just a basic understanding of like the difference between muscle, tendon, even to some extent joint pain, and how long it takes tendons to either settle or to heal or to deal with, I think is going to be really important information for people who exercise.
Because they are. Like, and they're often an injury or a complaint that you get in your middle to later stages of life. The only outlier really is patellar tendinopathy. And we'll talk a little bit about that later, or jumper's knee, as it's colloquially called. Basically, it's the young kids who play basketball or volleyball. Like, outside of that younger population that starts getting a cranky tendon underneath the kneecap, tendons don't really start showing up until our kind of third decade of life, our 30s, 40s, and 50s. So it's kind of like, why now? Like, why is it now in our life when we're trying to do fun stuff, or we're trying to keep the fun stuff rolling that we've done in our teens and 20s? Why now are these, Achilles or our elbows or our shoulders or our hips, why are they now giving us curry and, affecting our quality of life and affecting our ability to exercise and do the things that we love to do? And why do they take so bloody long to sort themselves out? That's the whole, I guess, premise of this episode is to give us all a better understanding. So as I said last episode, this isn't, a very physio-related topic. Obviously, it's got the physio underpinning, discussion points. But, if you're a young physio coming onto this episode thinking you're going to learn how to rehabilitate a tendon better, this one's probably not necessarily for you.
Go join up to learn.physio.
Generally, we've got a great one with Jill Cook and myself there. I just sit and just enjoy the conversation. But Jill put a great course together. But that's the premise of today's episode. So I guess if we kind of just start off, and this one's going to be a very different episode too from what we've previously done. Like I've basically just sort of got a little bit of nuggets of information from everywhere. Previously, when I've had a topic to discuss, I've pulled a really meaty meta-analysis or systematic review and sort of crunched it down and give us some numbers. This one's going to have far less of that, and this one's just going to be a little bit more about, the facts about the tendon, how it behaves. I'll have a few references along the way, but I have a reference list here if anyone is looking to get a bit of a better understanding, but I'm not going to be quoting, paper upon paper and stat after stat on this one. So this one's slightly different from our usual chats. But I think first and foremost, I want to set the scene of, what a tendon is and how it differs from a muscle. So, muscle effectively is made up a whole lot of cells. We've got actin and myosin, and basically, if we look at actin and myosin, they basically it's almost like a golf head club that sits on top of another area, a cell underneath it. And when that golf head club basically connects to the connecting tissue underneath it, basically latches in there and pulls and shortens and contracts. And that's how we kind of, get movement, and that's how we kind of, produce power, produce movement. And there's lots of blood supply to a muscle, and a muscle cell is ever evolving. It's got a continual turnover of cells, and so that's what a muscle is. Tendons, on the other hand, is made up of completely different tissue. We've got collagen that makes up a large part of what a tendon is. In adults, we're going to have, and we've got type 1, type 3 collagen. I don't know what happened to type 2, but type 1 collagen is effectively 95% of what will make up a tendon in an adult. The collagen is very different to what we have with our muscle cells. Effectively, within a tendon, we're going to have almost what's described as a matrix of tissue. So it's kind of like it's like a soup, I guess, but it's not a soup. It's basically a whole heap of ingredients sort of mixed into this tissue that basically forms into a tendon. And the thing about a tendon is it's got a very sparse blood supply, which is why it doesn't continually turn over. And interestingly, and I found this out in my kind of deep dive, the core of a tendon, and if we use the Achilles tendon as an example, the core of a tendon, the inside part of it, stops developing at the age of 17. And then effectively what happens around it as we grow older is that there's new tissue that grows around it. So it's kind of almost like a tree trunk. We've got that inner core, and then we've got this sort of new circulating tissue that goes around it that's kind of newer and stronger and evolves with us with time. But the inner core of it effectively, that's it. That's as good as we're going to get. So it acts and behaves very, very differently. I think the big takeaway here is often the muscles have got a rich blood supply, and with rich blood supply, we've got lots of, I guess, growth mediators and tissue and blood and oxygen and growth factors and all the things that all help grow a new cell and make it bigger and stronger. Tendons, on the other hand, just don't have that same rich blood supply that allows tissues to continually to sort of rebuild and turn over. So effectively, as we get into our late teens, what we've got is kind of the best we're going to get. And unfortunately, as time goes on, depending how we use our body, that inner core can effectively, start to die, but it's the outer laying and the outer casing of the tendon that's continually evolving, but it's much, much slower as we get older. So that's kind of setting the tone about the two different types of tissue and why one behaves completely different and how it's made up compared to the other.
Yeah, that's a good explanation. I like and it's very interesting about that core idea. I mean, I've just heard about that, but it's not discussed often, is it? Even in our circles about
no. Yeah. And I thought I knew most things about the tendons. I'm certainly not Jill Cook by any means, but I thought I'd sort of heard most things about tendons. But yeah, the core, and I like that tree analogy that has been put forward. So that's cool. Now we've got many tendons. We've got 600 muscle tendon units.
600. I didn't realise we had 600. Gee whiz.
Well, if you think about a tendon attaching one end to the next. So we've got, a tendon basically attaches to a bone. We've got muscle, and then we've got tendon that attaches to another bone. So there's tendons all around the body. We've got every little muscle all around the body. It's got to attach somewhere, and it's got to insert onto something. So there's, that number blew me away too when I sort of thought about it. I was like, okay, I can sort of see there's basically 2-to-1 ratio muscle. 2-to-1, there's going to be another one. But interestingly, what would you say is probably the most common tendon presentation? Like if you went to a sports physio clinic, a sports medicine clinic, what tendon do you think, is the most problematic that will take up a big chunk of a patient's day?
The actual tendon that causes most problems in the body, is that your question?
Yeah.
I would guess it'd be one of three. It'd be your common extensor origin. I'm only allowed one. All right, well, I'll tell you the three I'm thinking about. I'm thinking about Achilles, supraspinatus, and also your common extensor origin in your forearm. I'll go with the last one. I'll go with tennis elbow. Tennis elbow.
Well, no, you've actually of the list of the top 6. That's on the bottom. It's the bottom of the list. The most common, the prevalence. Yeah, the tendon. If to be fair, we're going to group all the tendons in the rotator cuff. So rotator cuff tendon pathology has got the highest prevalence.
Oh, there's 4 of those. Come on, it's
followed by the gluteal. So 5.5% prevalence.
Okay, there's 3. So glute med, glute mid, and then glute max. Okay.
Gluteal 4.2%. Yeah, Miller.
I want to have a word with him.
2021. Achilles 2.4%. Perineal tendons 2.4%. Presentation, patella 1.6%, tennis elbow and golfer's elbow clumped together about 0.7% prevalence. So yeah, the most but the Achilles and patella tendon often get the most amount of airplay.
Yeah,
largely because they're lower limb tendons. Lower limb tendons are springy, bouncy. Obviously, lower limb tendons are associated with our runners, our basketball players, both. Achilles and patella are massive injuries when they do occur in basketball, elite basketball in the NBA, obviously soccer players, AFL players, so on and so forth. So the lower limbs get a lot of interest and a lot of airplay, and a lot of research gets put into those particular lower limbs. So you'd be forgiven to think that they were high up in terms of prevalence, but rotator cuff is out by far and away as the more common presentation we'll see in the clinics. Maybe we just had a previous lower limb bias in our clinics, mate. If we worked in an upper limb clinic, sure, we'd have a different number. But interestingly, tendon pain, regardless of the location, has got a higher incidence than OA, osteoarthritis. So the annual incidence of tendon pain pathology that the person will seek treat, or the population will seek healthcare for, is 10.52 per 1,000 person years each year, compared to osteoarthritis, which is 8.4. So it puts head to head how much of a problem, I guess, or how much of a burden effectively tendon has on our physio clinics, GP practices, sports clinics, and so on and so forth. So it outperforms osteoarthritis, unfortunately. And accounts for 30% of all injuries in elite sport. But I guess the interesting thing about tendons are there's a lot of people who can manage, especially in elite sport, they can manage their tendon pain. You don't hear too many people missing a game of soccer because of an Achilles tendinopathy. It's something that often can be kind of co-managed. So they may have the burden, they may have the pain, they may have the dysfunction, but it often, very rarely, is the thing that kind of holds them out and stops them from playing, unless they rupture. And obviously that's a catastrophic event that sees them on the sideline for quite a long time.
And the good news for a lot of people who have got tendon pain is that if you're worrying about rupture, most of the time tendons rupture, there's no warning signal at all. They just go bang. And you find yourself in hospital literally 90 minutes later talking to surgeons. But grumbling, and my involvement in sport is that you're always managing grumpy tendons and in your stats back it up, 3 out of 10, 30% of elite athletes have got tendon problems. So it's a management issue, not a catastrophe for most people.
Yep, absolutely. And and you're right. It's a really good point, because I think a lot of people, particularly runners, and I come across a few people just in everyday life, they do worry about tendon rupture. And personally, I've actually got a real fear about rupturing my Achilles tendon. And it's something that's holding me back from playing basketball. Because really? I just know I've got a little history there. But it's because there's so much media interest at the moment. Last year we saw in the NBA, we saw 7 Achilles ruptures in the NBA. The previous year there was none. So even I'm just a big supporter of NBA, and there's definitely there's been a trend that we're seeing there. In the rugby league here in Australia, we saw 2 Achilles ruptures 2 weekends ago, back-to-back weekends. So there's enough media interest now where I think it's sort of front of mind. And I've had a couple of mates who rupture their Achilles as well. But I think also you get to this stage of life where you think, I can't deal with an Achilles rupture. Like if I was to go out and play a game of basketball, I just 3 months in a moon boot, regardless if I went conservative or surgical management, it's 3 months that will just really disrupt the kind of family mix. And that's something for me. It's just front of mind where it's like, risk versus reward is just not for me. But anyway.
And is there any commentary on the NBA stuff? Is it just a statistical blip that they've had a bad run this year, as 7 in there, or do they think there may be other factors involved in why there's been 7 in one season?
There's a little bit there. So I think that there has been pushback. So this was not the 25-26 season, but the 24-25 season. So it was the year that Halliburton, Tatum, Damian Lillard, and a whole heap. There was 7 high-profile names ruptured their Achilles. The previous year there was 0, and the previous 20 years before that was only 1.3 per year. So they were really rare. And all of a sudden now there was 7 in a year. So they did look at it, and they did think there was something there with the preceding, I think it was the preceding month of games, where if there was an increase in playing time by 10 to 15 minutes of what they would normally do, that was a link. So load management is comes to mind, and load management's a dirty word in the NBA and a lot of American sports, but there's something is, and it's happening in younger people too. Like I remember Achilles ruptures were a old man injury. It's a 30-year-old athlete. Like Kobe Bryant did his when he was 34, and a lot of the great athletes like Steve Waugh in Australian cricket did his in his 30s. And I remember it was an old man injury. Now it's becoming a young man or young woman's injury as well. So, athletes in their mid-20s, in the peak of their careers, are rupturing their Achilles as well, which you have to then start looking at their training methods, how much accelerations are being done in their training, how many plyometric sessions are being done collectively, and all those other little things. But anyway, I've digressed into tendon rupture land as opposed to tendons. But I think the nature of your discussion point, and it's really relevant, is that if you're worried about, if you've got tendon pain, tendinopathy and painful tendon when you run, probably don't worry so much, because tendons like this rupture under high force. And when you've got pain in the road and you can't produce a high force because of pain, you're not likely to rupture your tendon if you can't produce a high force. So yeah, anyway, there you go.
Exactly. Yep.
The interesting thing that I found also too with time and talking to Jill Cook and talking to Leanne Bissett, who also too is a wonderful researcher from the Griffith Uni, who does specialise in elbows, and so tennis elbow being tendon pain on the outside part of your tendon here versus golfer's elbow, which is on the inside part of your tendon here. The upper limb those tendons behave very, very differently to lower limb. So lower limb tendons, they're basically springs, particularly the Achilles and patella tendon. They are energy storage and release tendons. They take the load, they absorb it, and then they release it. So that's their design, that's their function. But the upper limbs, they're very different. They are what we call positional tendons. So they work very differently. They work almost isometrically, which is why, from, I guess, a rehab or an exercise point of view, you can't take the principles necessarily of how you would rehabilitate an Achilles tendon, where you would, do whatever you need to do to calm the tendon down. You build strength, you potentially work through some heavy eccentric loading, you then do plyometrics, so on and so forth. Upper limb tendons, they're effectively isometrics from day dot, and they don't respond at all to eccentric protocols, because when we do an eccentric protocol, you often get into what you get this compressive element on the tendon against the bone, and it continues to drive and annoy and irritate the tendon. So they just do not behave the same. So that's a really, really important distinction between the two. And the common symptoms that people will talk about when they've got an upper limb tendon, so particularly of the rotator cuff or particularly of the shoulder and the hip as well. The lateral hip is very different to patella tendon and the Achilles tendon. All those hip, shoulder and elbows, they are driven and often provoked by compression. So the lateral hip hates being slept on. They hate having legs crossed. They hate having their knees together, kind of thing. Sitting too deep in a car, sitting too deep in a chair really annoys those lateral hips. Shoulders, rotator cuff tendons hate, being slept on that same side, or if they roll over to the other side, same thing. They hate being sort of dragged across the body. So they behave differently. Whereas Achilles, it hurts when I run. Patellas, it hurts when I jump. Like, it's very, very specific and very load dependent to how they behave. So yeah, that's an important distinction.
Yeah.
All right. So over the years also too, the definition of a tendon and how it presents also too is changed. Well, it's evolved. So once probably back when you were training physiotherapy, and certainly it started to change a little bit in the kind of late 2000s for me. Tendonitis was the way we would describe how a tendon would present to you in the clinic. And what the belief was at the time was that the tendon was inflamed. And that was kind of like the way we understood it. And then, over time and through great research and through the 90s and 2000s, we started to realize that actually beyond a certain time point, the tendon actually wasn't inflamed at all. It actually was started to degenerate. and certainly parts of the tendon, particularly the Achilles tendon and the patellar tendons, we would start to see that, particularly that inner core, start to become less useful and show signs of degeneration. The outer layers were probably a little bit more thickened compared to the other side, and so we started to have what's called a tendinosis, and our changing terminology was a tendinosis. And then in 2019, a whole bunch of smart researchers from all around the world got together for an international conference and consensus meeting on tendon pain and tendon pathology, and they all agreed that tendinopathy would be the way that tendon presentations would be best described, as it's a load-related problem resulting in loss of function. So that's kind of like where we stand. And very rarely now would we see a true tendinitis presentation. Like I can't think of too many. I know there are obviously some kind of unique times where
you can
we
get
see
them.
a tendinitis.
Yeah. Paratendon, like down in the Achilles, and especially if someone gets like a compression kind of whack through there, that kind of thing. But it is unusual. And I think your point also is the proof's in the pudding. How many times would you say that patients would come in and say, I got tendinitis and I've been taking ibuprofen, or I've got some anti-inflammatories from the pharmacy and it's not helping me at all. It's like, because generally, particularly the chronic ones, are not inflammatory. So and ice doesn't help either. So it's all got to do with making sure that we get it strong and letting that tendon settle down slowly, as you said, particularly because it's got such a poor blood supply.
Yep. And the tendinitis is probably less, it's for those presentations that are around and that have some degree of inflammatory driver to it. Probably the biggest problem with calling it an itis is that it kind of encourages and evokes a treatment response that's quite passive, where it is rest, it is ice, it is taking it easy and letting that inflammation settle. Whereas tendons, and as we'll sort of go through the next little bits of this talk, is that tendons actually, they hate rest. Well, they love it in the short term because you're not loading it, but ultimately they need regular and consistent loading, and they actually love consistency. They hate change, and they don't respond very well to change. So, we see when you rest a tendon, it often feels good. Your symptoms abate, but then all of a sudden you go to reload because you're feeling good again. All of a sudden now we're seeing pain again. So the key thing here is trying to sort of manage it so that we don't rest too much. And that's what an itis, I guess the terminology of an itis doesn't sort of help how we manage it, because it does evoke this thing that we need to hit it with medication, or we need to hit it with cortisone, or we need to hit it with things that will address that inflammatory nature when there's not much of it, if any. So when a tendon goes through stress, and this is thanks to the great work of Jill Cook and Craig Purdon, we've got a typical stage process where when a tendon is stressed and overloaded to start with, it goes through a reactive stage. Okay. And so in the short term, we often get thickening of a tendon, and this classically presents when someone who is younger and there's been a training spike and the tendon is thickened and sore. So think about the young, mid-20s person who's all of a sudden now gone from 2 running sessions a week to all of a sudden and 4 hill sprints per week, and they're coming in with this really thickened, creaky, annoyed tendon that's quite stiff in the mornings, painful at rest, wakes them up at night time. There's usually the usual tendon behaviours. These ones, if you catch them at this stage, the pathology is reversible. So the tendon can just look really crappy on a scan and it can appear crappy in the clinic, but the tendon and the person's young enough so that inflammation and all those kind of things that are driving the pain is reversible. However, if we let a tendon kind of continue to grumble along and evolve, when we don't have things sort of, the training principles right, the tendon can move into the next phase, which is disrepair. Now, the disrepair is when the tendon is trying to heal, but effectively will go through more tissue breakdown. And there's more things within the tendon unit, which are called proteoglycans, that basically disorganizes the collagen within the tendon, making it thicker, making it less likely to absorb and transmit forces and allow those tendon cells to get sliding over each other to transmit those forces. That just becomes completely disorganized. And this is the one that often will present. And there is some degree of the tendon being able to reverse when we move into this stage. So the changes can reverse partially. Once again, a lot of people will kind of grumble through this period. They'll kind of be able to manage through, and then sometimes we'll see the person who's got a truly degenerative tendon where there's effectively cell death within the tendon at some points of the tendon. Usually the inner core has become, pretty useless and has effectively died off. And it's usually the older athlete with a long history of grumbling tendon pain, such as myself. Not that I'm an athlete, but someone who's poorly managed a tendon over 20 years. I've probably got no doubt some degree of degenerative tendons in my Achilles, but these tendons certainly don't have any chance of, I guess, coming back to life, so to speak, on the inner core. But the beautiful thing is that outer core, as I said, like a tree that has these evolving rings and new tissue that can lay down over and over again, that stuff there is beautiful and can be used and will allow you to be able to continue to do things that you want to do, which is why, and this is probably we can probably start talking about this now, this is why treatments such as PRP and cortisone and some other kind of injectable things that have been sort of promoted to change and improve the tissue quality that has died, that's why those things don't necessarily work. One, because you're sticking a tendon sticking a needle into a tendon that doesn't particularly like having something stuck into it, but also two, what it's proposing to do on the inside, it effectively doesn't sort of matter, because that healthy, thickened tissue on the outside is actually just as useful and more than useful than what you're trying to sort of put into the tendon to try and create a revitalization, so to speak, of what's happening and what's died off. So those degenerative tendons that you may see, or you may, your doctor may, say that you've got a degenerative tendon, or your ultrasound may show signs of degeneration. Don't stress about that. Don't worry about that, because you've got a whole heap of thickened and beautiful, healthy tissue on the outside, and that tissue on the inside that has effectively looked a little bit dead. It's okay.
Yeah,
it's okay.
I'm glad you said. I'm glad you went through that, Mick, because I think that we get that all the time, where people will get the ultrasound done, the GP or the doctor will kind of refer it off, and we will get them and they'll say, "Listen, I've got this dead bit of Achilles or this dead bit of my supraspinatus or whatever," and it's like, that's never going to heal, and that's what's been told to me, and it can really put people in a rut. It's like, I've got something that's never going to get better, and it's like, yeah, well, that may be just that tiny little black spot that's on your ultrasound, but the rest of the tendon can get better, and it can get stronger, and it can supplement and augment, essentially the stuff that's not quite normal there, and you can improve. And I think it's really important that people understand that, because if you think it's just a degenerative condition that can never improve, then people can get down the dumps. They don't exercise. And it can have more flow down effects than just kind of like a sore Achilles, for instance. So I'm glad you went through that as you did.
Yeah, no, all good. So I think that's where we sort of we go through the stages of what's going on. But I guess the big question is, why now? Why at 30? Why at 40? Why at 50? Why is this something that's not coming earlier? And effectively, it's basically, as I've kind of half sort of mentioned, it's that accumulation over time. Like if you've been a runner that's clocked up a lot of mileage, or you played soccer, you played AFL, you played netball, over the years there's going to be a limit to what your tendon can do. And as we said, as by the time you're 17, 18, that core of the Achilles tendon, if we're just focusing on that for the second, there's no capacity for it to, basically get any stronger or bigger or have more capacity to build on the inner core of the tendon beyond the age of 18. But the outer layer is the kind of thing that continues to grow very slowly and does adapt positively over time. Now, it's just that those outer layers, they're the kind of the outer layer of the tissue is going to be, I guess, younger and immature, and it's going to be that's going to be the thing that takes time to slowly adapt to things. So that's why there comes a point in our life where 30s, 40s and 50s that we're starting to see all of a sudden now symptoms creep in. And the classic symptom of any kind of lower limb tendon, be it Achilles, be it patella tendon, be it gluteal, we're going to have that morning stiffness that's usually sort of cruises around for the first 5 to 10 minutes of the day. That takes a bit of time to warm up. And then when you're doing something, be it run, be it jump, often there's a bit of warm up or activity related pain there that often eases off and then goes away magically. Like that's the thing that often, people will talk about. It goes away and then all of a sudden it comes back to bite me and cools down when I cool down. And then sometimes it gets a bit achy at night time. And that's the typical behavior of a tendon. But it's often what I sort of explain to patients is when you're in your 30s, right? We talked about this in previous episodes. The fun stuff that we want to do when we're in our kind of 30s, 40s, and 50s, because we have lost there's a lot of different factors, but certainly underpinning a lot of lower limb tendons is going to be a lack of and a reduction in strength over time. So if we sort of use like a little graph here, in this way I'll describe it to a patient, the fun stuff that we want to do is a constant. So if we want to run, the loads that we come across is going to largely stay the same. So, whether or not you're 30, 40, 50, the line that we sort of see over time is going to stay the same. But our strength, however, once we hit sort of 25 or 30, our strength, unless we're topping it up each and every week, we're on a bit of a slow, steady decline unless we do something about it. And there's going to be a gap there that starts to allow some of these symptoms to creep back in depending on how high and how hard we want to use our body. So that's the kind of thing that no doubt starts to weigh into the presentations we see. And for me, that's why, I often counsel people about what things can we do. Obviously, we've got to get rid of the irritants. And if something is irritating your tendons, be it running, jumping, the way you sit, the way you sleep, the way you work, how many hours you work, or your positions that you get into, we have to acknowledge those irritants and try to modify them. And then we try to build up that capacity around them. But that's probably the easiest explanation that I try to sort of say to my patients is that, often we can get away with things like this in our teens and our 20s because we've got, these young, healthy tendons that are able to store energy, and our strength that we've got on board and our activities that we're doing. It's often very well matched, give or take a few percentage points above and below. But once we hit 30s, 40s and 50s, our work demands start creeping in, our lifestyle, our sleep, our habits, the way we eat, the way we drink, the way we're stressed, all these things will drive how our body will, tolerate pain and how we tolerate load. And that's why we're starting to see a little bit of an uptick in our presentations when we see patients in our 30s, 40s and 50s. The caveat is young people with patellar tendinopathy. That's the one thing that's very different. It's very much your patellar tendinopathy person, jumper's knee. It's very much an exclusive young person, volleyball player, basketball player presentation where we just get a whole heap of jumping on a tendon that's not quite ready for it. And we're seeing the peak incidence there at about 15 to 20 years of age, and about half of all elite jumping athletes will have some degree of patellar tendinopathy at some point in their careers.
Yeah, no, that's a good distinction between the two groups. And I think there's also like that middle group as well, where when people, whether they're young or whether they're a bit older, haven't exercised for a while and then they go back and get back into it. And clearly, like if you start running again, you're going to get a bit sore everywhere. But the muscles can get strong reasonably quickly in relation to how quickly the tendons can adapt to that kind of load. And it's not only those impact sports, but I've had a number of, over my career anyway, a number of people who have got into strength training. And some of these people have been on steroids, for instance. And they have put on so much strength and muscle so quickly, and the muscles are fine, but they're coming in, their tendons are screaming. And it's the reason is you're pulling on those tendons so hard with your stronger muscles that they haven't kept up pace with basically how much load is going through them. So you have to, I hate to say it, but you have to get less strong or do less to allow your tendons time to improve. That, I suppose, what we're speaking about now is the complexity of management of tendons. Sometimes you're doing too much, sometimes you're doing too little, sometimes it can be age-related, sometimes it can be overload, sometimes it can be, for people who are 15 to 20. I think that, clearly it's great to have understanding of it, but if you do feel like you have tendon pathology and tendon problems, go and see a health professional to make sure you're doing the right stuff at the right time.
Yep. Yeah, agree. So what helps? I think, we hopefully have sort of set the scene as to, how what it is, how it evolves, why we're seeing it. But effectively, what can we do if you're an everyday listener, if you're a young health professional that's sort of, cutting your teeth in this area? I want to start with a little story about, the godfather of tendon research, Harkin Alfredson. You might have heard this story. I think we talked about this in a previous episode where he had a really nasty case of Achilles tendinopathy, and he got to a point where it was so debilitating. He was a recreational runner. He was very frustrated and he was loading it hard. And he actually went to his boss and said, look, he worked in a Swedish hospital. And the surgeon said, no, I can't operate because we're going to lose you. We need you on our staff. We need you there. So he went off to the gym and he tried to break his Achilles tendon by basically doing a whole heap of eccentric loaded exercises off the edge of the step, got his painful tendon, dropped it over the edge of the step and tried to effectively break it by doing these heel raises off the edge of the step up and down again. Lo and behold, what he was doing is actually making it stronger and tougher. And actually within 4 or 5 weeks, it got better and he was jogging again after 4 or 5 weeks. And then that was the catalyst to his now famous 1998 paper and his heel drop protocol, which was, it's always an interesting story, which I love to hear.
Yeah.
But effectively, the Achilles in particular, patella tendons, they love load. They respond really well to load. They respond well to consistent load. Now, there's lots of different protocols you can take. I'm not going to go into them today, but they do respond really well to exercise. But the key thing is trying to, in the short term, when they are presenting, is to kind of, I guess, respect the irritant. And now and that's the thing with an Achilles, it's going to hurt when you run. It's not going to hurt when you walk. You might notice it when you walk up and down a hill, walk up and down stairs, but initially when it's becoming painful and it's affecting your exercise, then we've got to reduce that irritant to start with. But it doesn't mean we have to completely stop. And that's the thing. Like there's lots of other things that people can and should do. And same thing with jumping. Like a patella tendon is not going to get that cranky in going for an exercise bike ride. It's not going to be that painful to go for a walk. So you avoid in the short, you reduce the irritants in the short term, and then you gradually reload and stack load on top of that. So we know loading really, really helps. The problem which I think a lot of people face is the fact that it takes a long time to build a robust, strong tendon and take people through the steps that, calm the tendon pain down, build the strength that's required to do the activity, do the stuff such as plyometrics and jumps that help the tendon become and behave like a spring again, and then kind of let them go. That whole process can take, at least 4 to 6 months. And for some people it might take longer. So it's a really frustrating and long process, and very different to those muscle tears that take, 2 to 4 weeks, better again kind of thing. So that's where the expectations of you as a patient needs to be. If we're coming in with a tendon thing, expect this is going to take at least 6 months, maybe even more, and it may be something you just have to learn to live with and learn how to manage, because the tendon certainly can get to a point where it actually might be something you just have to manage for the rest of your running career or whatever it is that you like to do. Importantly, I want to talk about, because there's other things that make it better. But importantly, what I want to get into also too is what will make it worse, because there's lots of things that you might see and clinicians may sort of hear and see on the internet. People may, come to the clinic and say, can this work? Does this work? Corticosteroids. So, you go to your GP and you go with a case of, Achilles tendinopathy or gluteal tendon pain, rotator cuff. Often you'll get offered a cortisone. Usually you get a really nice pain relief effect. 6 weeks is often the classic kind of pain relief response for your first time responder. And we've seen that in head-to-head studies, particularly around the elbow, particularly around the shoulder, and also around the Achilles as well. If you look at a control group, if you look at an exercise group, the cortisone group in terms of pain outperforms the comparison group by 6 weeks. Go to 6 months and go to 12 months, then the cortisone group is actually worse than the wait and see or the other intervention. So that's an important distinction there, is that if you've got an event coming up that you really want to get up for and it's your once in a lifetime event, and it's going to be something that, if you don't do this event, you're going to always, regret it and be annoyed by it. Cortisone within a 6 week window, it seems like to be something that you wanted to help, but I'm not saying everyone should go and get cortisone. But know that 12 months down the track, you're actually going to be worse off for it. So that's an important thing that each person needs to weigh up, is how important is getting a cortisone injection for you, because there's far better ways to manage a tendon-related pain if we don't have something super important within the next few weeks. So corticosteroids or cortisone, not great. and certainly in the long run, worse off for you. PRPs also not good for you in the long run. And I've always sort of wrestled with PRP. Like, it's a bit of conflicting research out there, but talking to a couple of researchers today on tendon pain, a lot of the head-to-head studies with PRP, or some of the meta-analyses, they've actually compared PRP versus cortisone, and PRP does come out ahead versus cortisone, but they've actually never had another control group or another comparison group. So PRP versus cortisone, yeah, PRP better. But there's a lot of unknown as to how it would go against wait and see and do nothing, or potentially exercise or something else. So PRP, a very expensive process to potentially, get better than cortisone. Surgery, not at all advised unless you rupture a tendon. And certainly, last resort, if you've got a really crappy degenerative tendon, but still, obviously, the outcomes are going to be pretty poor if you go down the surgical route. Testosterone anabolics and peptides, we've seen some higher re-rupture rates in our tendons, particularly with steroids and testosterone use across multiple tendon sites. So biceps, quad tendon, patella tendon, Achilles tendons, supraspinatus have all been shown to have higher rupture rates of those tendons when testosterone use has been done in the previous 12 months. So something to avoid it's certainly probably why we see a lot of bodybuilders, unfortunately, rupture their tendons in multiple sites because of what you said before, but also too the negative effect of the cortisone. It actually does harm to your tissue. Not only is it not only is it the fact that, degrading to the tendon tissue, it adds, not only is it pulling on muscles and tendons that just aren't equipped for it, that it does harm to within the tendon. So they're the kind of main players. There are other things like fluoroquinolones, metabolic disorders and that kind of stuff that also too have, pretty harmful effects to the tendon as well. So there's a lot of harm. There's a lot of harmful things that we can take for tendons that are not great, but there's a lot of good stuff out there, and exercise should be up there, and progressive loading should be up there in your choices of things to do.
Load and strength, always number 1 and 2. Like, if you haven't done that properly, don't consider any of the others.
Exactly right. And avoiding too much rest. And I think we haven't sort of said that, avoiding rest. We don't want to have too much rest. There's going to be some cases where some short-term rest is needed to calm a tendon down, but that should be bare minimum. We should not be having too much time. I'd comfortably argue we should probably not have more than 3 days of absolute rest when we're seeing a really cranky tendon walk through. There's plenty of things that the person can do for that tendon. That's nearly it. I've just got 5 tips here to round it out, mate. And this all comes courtesy of Jill Cook. We've got. And we've probably said it all along, to be fair, we don't want to rest the tendon completely. We've got to modify the load and try to really reduce how much we remove the load. Importantly, when we look to load a tendon or we exercise or do any things that we enjoy doing, watch what the next 24 hours brings. If you're waking up, you go for a run, you go for a jump, you do something on a Monday, how you wake up the next day, there's going to be an expected response there. Usually I use a pain scale. 0 is no pain, 10 out of 10 is worst pain. We don't want to see what you would normally wake up with. If you wake up with a 2 out of 10 pain, that's your baseline. We don't want to see you wake up with more than a 4 out of 10. So I try not to get people to exceed their pain baseline by more than 2 points. If that has been exceeded the next morning when you wake up, we know we've overcooked the tendon, and we know we probably should scale things back the next time we feel ready enough to do that. So watch that 24-hour response. That's the key, because a lot of tendons actually won't be pain-free. And to be pain-free kind of often means that you just need to really stop doing the things that you love doing. So if you really love to run, you really love to ride, we've got to expect probably a few little grumbles along the way, particularly if we're managing a rehab tendon. So use that 24-hour rule as a good rule of thumb. Importantly, give it months, not weeks. As I said, this one, a lot of lower limb tendons, a lot of tendon pathologies will take minimum 6 months to get right and to get back to a manageable stage where you're back doing the things that you love doing. So this isn't a muscle. This won't take just 2 weeks till it feels better. This will take months. Be skeptical of anything fast. If someone's promising you a quick fix, a PRP injection or some kind of injection or some kind of medication or some kind of expensive supplement, be very skeptical and be very wary of that, because the evidence in that space is very thin and you're probably going to spend a lot of money for not much reward. So just be very skeptical about that. And lastly, get strong. There's certainly no harm in getting strong. There's probably the harms come when you get strong and you have a few injections along the way too. So be a natural, strong lifter and have that nice strength on board to complement the fun stuff that you like to do. So that's the Tendon podcast episode.
There we go.
Done,
Exercise Matters listeners are now experts in tendon pathology and the pathway mix. So well done on going through that. It was hard to hold back actually, like during a lot of that, because there's so many things that you and I can kind of talk about in depth. But as an overview, I think that's excellent. Hopefully, people understand a lot more about tendon injuries and tendon pathology, and that it does take a while for them to get better.
Yeah, I agree, mate. So hopefully there was something in that for everyone, mate. So thanks for being patient. Thanks for sticking with me. That was a long one, 55 minutes, and hopefully I gave the tendon breakdown a good level of service. And it's an area of my interest, but I'm certainly not an expert by any means. Jill Cook, Peter Maliaris, Karen Silbernagel, just to name a few. Patrick Valance, really great names. If you're listening to this podcast and you want to learn a little bit more, I'd certainly have a look at some of those four people in particular. They've done some great work, and a little bit of extra reading there if you want to get into that space. But that's it for today. And that's a wrap for this episode of Exercise Matters. If you enjoyed the chat, make sure to subscribe, leave a review, and share it with your mates. A quick disclaimer, this podcast is for educational purposes only and is not medical or individual advice. Please always seek guidance from a qualified health professional for your specific needs. A big thanks as always to our sponsors Premax, high performance skincare for high performance people, and Learn.physio, world class education for health professionals. We'll catch you next week.